It's a real honor to be here at the first Public Health Summit at this amazing institution. It's just a real honor to be able to introduce myself and what we're trying to do at UCSF and try to make a difference in public health. Let me see if I can bring up the slides here. There we go. Excellent. So it's my pleasure this morning to talk about how we're trying to find, use, and disseminate almost 1 trillion points of data for public health. And when I talk about 1 trillion points of data, I think it's no mystery to any of you that we're in the middle of what they call a data deluge. The Economist magazine, if you haven't heard, said 3 years ago, the human species generates 2 zettabytes of data every year. 2 zettabytes of data. Now, I'll be the first to admit most of these zettabytes of data are YouTube videos of kittens playing with pianos and yarn. Entertainment value, but perhaps no scientific value. But there is scientific data in the zettabytes as well. And in fact, there's not just scientific data, there's biomedical data. Let's get the slides back. Here we go. And we have biomedical data like this. Now, I carry one of these in my suit. They're so cheap. On the left there is what's called an Affymetrix gene chip. Now, you heard about how we have genomes and how we can look at genes. On the left there, and I have one in my hand here, okay, is what we call a gene chip. Now, this just represents all the molecular technologies we have, whether it's DNA sequencing or RNA or proteomics. I don't care. This one looks cool. It fits in my suit. And it's so cheap. It's a couple $100. So you can put any sample of cancer or diabetes, and you get a readout of the whole genome on this chip. And what happened is we get tired now of measuring them one by one. So we measure them in the 96-well plate. And that's so cheap, I can carry that in my bag. And then we got tired of measuring them in the 96-well plate. And we now measure them in the 384-well plate. That's so cheap, I can carry that in my bag. So we don't even bother doing one sample at a time. We can do almost 400 samples at a time. I cannot more clearly illustrate the exponential growth in biomedical data than to show you these plates and how amazing it is that scientists can just measure and measure and measure thousands of samples that we collect every day in our hospitals to learn something more about our patients. And that's the kind of goal, that's the goal. In fact, what's also changed is that these technologies have been around for almost a decade or two. Every researcher at this institution, my institution, most researchers use these high throughput measurements for biology. What happened is the journals, the scientific journals said, hold on a second, we're getting too many of these papers now. Here's a list of genes, there's a list of genes, who cares, right? We're getting too many of these types of publications. No more papers with these kinds of chips in them. Unless you make that data publicly available, open to the public, so that the reviewers can double check the math. It's probably getting important to do that. And maybe the public can use those samples for something else, for new science. And fast forward to August of 2012, this article came out in Nature, featured my lab and many others, where in August of 2012, we hit 1 million of these chips publicly available now. 1 million samples already collected from some patient, some animal models, some cell lines, some disease. Someone wrote a paper, someone analyzed the data, and the data is now open to the public. Now, if you look really carefully there at that kind of bar graph, you can see it goes from 0 to 1 million. And it kind of looks sad. It looks like it's kind of slowing down there at the tail, right? And then you realize they only counted half the year. This came out in August of 2012, right? We're still doubling every 2 to 3 years. In fact, we're just shy of 2 million samples now publicly available. I'm just using this as an example of one kind of molecular measurement. They're all growing like this. Not only is every biomedical database growing exponentially, the number of biomedical databases is growing exponentially. That's an exponent of an exponent, which the mathematicians will tell you that's still an exponent. I know that. That's how fast this data is growing. Now, what are we going to do with this data? Well, any one of our scientists can go to these websites and search for breast cancer or prostate cancer and try to start with data. Instead of starting with a pipetter, start with the data. Well, actually, forget about our scientists. Even a high school kid can do this, right? A high school child now who needs to do a science fair project. She can go to these websites, and she can click, and let's say she's doing a science fair project on breast cancer, and she can find and search and download almost 60,000 samples of breast cancer. You can see on the website here, 60,000 samples of breast cancer she can find and download about as easily as she can find a song on iTunes today. Right? Search for breast cancer, 59,000 samples publicly available. What an amazing time it is to be in biomedical research. I know the funding is flat. I know we're all trying to get more funding. We have these new initiatives that we're going to be talking about. And then they give away 1 million samples like this because of this community of sharing that we have in biomedical research. I know people are strong-armed into doing it. I know there's carrots and sticks. But isn't it amazing when even a high school child can find and start an experiment with 60,000 samples of breast cancer or colon cancer or prostate cancer? To me, open data is the most amazing export from the Western world. Why do I say that? This is a public resource that we export. Think about other public resources like oil, right? If I take oil from public land, you can't have that oil. I know in California, if I take water from public land, you can't have that water. But if I have data, you can have that data too. And I might make a diagnostic with it. You might make a therapeutic with it. And as the intro video said, I think data is the most amazing concept. We can export this to anyone in the world. And a kid in Bakersfield or Bangladesh can make $1 billion drug with this data, sell it back to us for $1 billion, and we're happy with this story because we need those drugs, right? Nothing beats data as an export, right? Just in terms of value creation. So what are we all going to do with this data? Well, no one's actually mentioned this one phrase that everyone's talking about now this morning called, this year called precision medicine. A bunch of us were here just last week at the White House talking about the 1-year anniversary of the announcement of the Precision Medicine Initiative. And I'll be honest with you, I mean, President Obama said a lot of things. In fact, I wonder if how many people in this audience actually think precision medicine's the opposite of public health. I want to make sure nobody feels that way here, right? But I wonder if some people actually feel that way. President Obama had one thing that I made sure I tweeted, and I think others did too, is that precision medicine is not a substitute for basic health care, okay? We always better remember that this only works if everyone has basic health care too. But actually, precision medicine makes a bunch of doctors nervous, right? Because if we're entering a precision medicine era, that means the last thing we were doing was not really precise medicine, right? By definition, right? So how do you actually measure the precision of a medicine? Well, the way I think about measuring the precision of a medicine is by thinking about how we classify diseases, right? How do we even put pigeonholes? Or how do we put the patients in one category versus another? This idea of classifying diseases goes way back. It's actually started as a public health effort. The London Bills of Mortality in the 1600s, right? Lists of ways that people were dying in London. That's a classification. Actually, the word for this is called nosology. Nosology is a systematic classification of diseases. It has nothing to do with your nose. And for hundreds of years, we've been trying to come up with the right way to classify diseases. In fact, I buy books like this now. When old physicians die, they throw out these kinds of books. These are how we used to classify these books. This is the International List of Causes of Death, ICD. We know ICD 9 and 10. This is ICD 2 from Paris, 1909. And it's amazing, you know. I mean, you can buy these in people's trash. And it's kind of written the same way that our current books are. You know, someday ours are going to be trash, right? But, you know, the code books of, you know, use this code and use that code for different disorders. And literally, this international standard has to say, if you run into a patient that died because of a visitation of God, be sure to use code 189, right? Oh my goodness. This is an international standard has to say that, right? Now, people laugh at our code books today. I mean, forget about waiting another 100 years. They're going to be laughing at us in 20 years, right? Those silly fools didn't know this disease and that disease were the same thing, right? That's what they're going to be saying to us. And I know that last year we underwent a radical change to something called ICD-10, the 10th edition of this book. You know, it hasn't changed that much. And everyone was teasing about ICD-10 because we're trying to be more precise. There's a code for this, and there's a code for that. There's a code for surfing and getting hit by a whale. There's a code for a lot of these. There are a lot of memes floating around. My favorite meme was this one. I don't always get sucked into a jet engine, but when I do, I use code V97.33XD. I loved this one, right? Now, my friends in San Diego said it is possible to get sucked into a jet engine if you're on an aircraft carrier, but I do want to point out, I've been told This is the chronic form of the disease. So I can imagine it happening once, but probably not twice, right? But there's a code for it, right? But the way you're laughing at ICD-10, we should have been laughing at ICD-9. ICD-9 is what we should have been laughing at, right? How do we code lung cancer? For example, we talked about smoking this morning. How do we code lung cancer at ICD-9? Do we take advantage of all the molecular testing in ICD-9? No. Do we take advantage even of the microscope to know is it small cell or non-small cell or adenocarcinoma? No. This is the code for lung cancer, 162.9. Do you know how we code lung cancer in ICD-9? Left lung or right lung. Literally, that's how we do it. And ICD-10 is just the start. We got to get way better than that. Right? It's not even fixed in ICD-10. We got to get to way more precise medicine. And this is just the start. Because we have to get to a code system that we can communicate to each other what our patient has and communicate to electronic systems what we think our patients have. So we want to revolutionize this, not just basing what kind of doctor takes care of a patient, but what the molecules look like in the patient. And that's what we start an effort to do, is really start to look at all the molecules of all these different diseases using these kinds of chips. And not just using the chips, but using the publicly available data on these chips. So on the left there, it's a complicated slide. On the left, we started to collect experiments where people looked at a disease and healthy using these chips. And this is all from the NIH databases. And on the left, we started to gather experiments where people looked at a drug and no drug, with and without a drug. So we got disease and no disease on the left and no drug on the right, and we put these two together. The reporters on this call this match.com for drugs. You're trying to make a match, right, between drugs. And we start to get predictions. You know, this drug looks like this might work on that disease. And where we had a lot of traction is figuring out not just the new drugs, but here's a new use for an old drug repositioning. It also came up in the panel just now. And we know all the famous examples of drug repositioning. We know that cardiac drug that had an interesting side effect of hair growth. Of course, that's minoxidil. Everyone knows the other cardiac drug that had its own interesting side effect. You know, of course, that's Viagra, right? And Viagra's done a double switch, as Revatio opens the blood vessels from the heart to the lungs as well for babies with pulmonary hypertension. So people tease about babies on Viagra. But you know what? Instead of finding them by accident, how about we find them on purpose using public data? And that's the kind of concept here. And the one I'm really most proud of, these stories, is this one. So here's an example. What happens when you think about diseases, not based on the code books, but the molecules. Here's an example of a psychiatric drug, imipramine. It's an antidepressant that we showed works on small cell lung cancer. You all know humans smoke to get small cell lung cancer. It's a 5% survival rate. And this mouse, you knock out those 3 genes there. You can see the team on the bottom right there who's worked on this. You knock out those genes, and you can see the nodules in the top left panel. You can see the lung nodules, the lung cancer in the mouse there. And the right side, these mouse lungs, the right set of pictures is treated with this antidepressant, imipramine. Now, imipramine is still in the pharmacy. We don't use it because we have serotonin reuptake inhibitors like Prozac and others. Imipramine had some side effects. It made people sleepy. And in some people, it might have set them up for what's called QT prolongation, might set them up for an arrhythmia. Actually, neither of those two side effects sound as bad as having lung cancer, 5% survival rate. And it's gone, it's melted away in this mouse. Now, why do I love this story, right? Because we start with public data that any high school kid can get to. We had this computational prediction. We test cell lines in a dish. I'm not even going to show you that. We get this mouse model to work, and 15 months after the computer prediction, we got ethics, IRB approval, and we launched a clinical trial, and patients are dosed on this drug now. Total cost of this trial, $50,000 bucks. Not even $1 million, not even $100 grand, right? It fits in what we call the seed grants here. Now, this drug may work or not work. It does not matter. We have to try more of these. I know, because I essentially consult for every major pharma and biotech now. There are not enough of them to actually address all the diseases we need to get addressed. We need a new tier of players here. And I think those kids that are sitting in garages, right, that are there, they're just making yet another way to share pictures with each other. We don't need another one of those, right? We need them to work on cancer drugs and diabetes drugs. That's where I see the future, in these garage biotechs. We love garages in Silicon Valley for some reason. We revere them, right? Apple and HP and all the rest of these, right? But it's not just to start the companies, it's also to actually help patients like this. Now, on this slide here, I always show this slide. When we were launching the trial, we got emails like this. October 8, 2013, hello, my name is, I need help, I'm an Italian man, I have 3 children, I'm 48 years old. On June 5th, they told me I have small cell lung cancer, neuroendocrine tumor. Today I work 75%, I have different mets, liver, kidney, pancreas, skeletal. I know I will not live longer than a few months or over a year. And these are the emails I was getting every couple of days when this trial was running. There are so many more patients out there. And this, to me, is public health, is treating them all one by one, right? That we can actually do this one by one. This guy is already gone. I got this email in 2013. We have to do more of these and get a new team of entrants in developing these kinds of drugs. And that's my new role at UCSF now, is to actually build out this team and actually get some of this work really done. Let's see if I can get the next slide here. Let's skip this slide here. So I'm really pleased to be at UCSF now, and just to wrap things up, I'm slumming it out in that brand new building until they build our brand new building in 2019. If you've ever visited San Francisco, come to Mission Bay. It's an amazing new development. We have a brand new hospital for children and cancer, a precision cancer hospital now also being built. But the real reason I moved to UCSF was because of something called UC Health. Now, something I never knew, even though I was down the road at Stanford. The University of California system already participates as one. So we have 5 health systems: UCLA, UCSF, those are bigger ones, Irvine, Davis, and San Diego. So it's 5 major health systems all participating as one. And amazing to me is that we actually already all share our data with each other, actually. And now I get to build out the electronic data warehouse of all the electronic medical records across all of the patients in the University of California system, including 14.1 million patients in our system. So about 4% of the US population gets its care at the University of California. And what does it mean for us to share all our record data with each other? Well, that means all the Epic and Allscripts and Cerner, we're putting that all into one place. I know I've been told interoperability is hard. I don't care to hear that others think it's hard. We're going to do this. We've already done this. We're getting these numbers to line up. It's not rocket science. It's just engineering. We can do this. And what are we going to do with this? We're going to improve the care that we deliver, obviously. We're going to deliver some of this data to app developers and entrepreneurs of the state. And for me, one of the things I want to do is I want to start to build maps. Maps of how patients get disease and die in California. So here's an example of a map. Here's my favorite example. So the circles are diseases and the squares are death. You know, not to be morbid, but everyone's got to die of something in the world. And actually, if you've never been on call, you might not know it's illegal to die without a disease in the United States. Someone's got to put something on your death certificate, right? It's illegal. You got to have something there, right? You might have had the disease for 1 minute, but you're going to have something on your death certificate. So we keep track of all those in California, of course. So here's an example of a map. So that top left circle is alcoholism. Someone comes in for alcoholism. Statistically, within a year, they come in with chronic liver disease, and they die of that. That's going the right path. Or they might come in with liver abscess and then die of that. So every arrow here is an actual 1-year kind of transition. They get kind of complicated. On this one, you see, you start with a heart attack. Now, I didn't know this. People with heart attack get heart failure. I knew that. But then they end up with lung diseases, and a whole bunch of them die of septicemia. I didn't realize a lot of people die from a heart attack because of sepsis, actually, about 3 years later. And you can see how people can diverge and die from all these different paths. And that's what we're trying to build, are these maps. It's like kind of Google Maps, but instead of going to a pleasant destination, this is how we're going to die, right? But it's going to be better than Google Maps, because what's wrong with Google Maps? They actually don't show you where the cars are, right? It kind of shows you a map. It might show you some traffic patterns, some statistics. And in that brand new building, in 2019, when we open our doors, we're going to have a room with this big bank of monitors, and we're going to have our maps of human health and human disease on that monitor. And what I'm going to do is I'm going to start to track every one of our 14 million patients in this way. Now, this is a prototype here. Every dot here represents about 100 or 500 different patients moving from disease to death. And I'm going to have all 14 million on that wall. And I'm going to know what's going to happen in the next 90 days. I'm going to know what's going to happen in the next year. And what are we going to do about it? And this, to me, is going to be the new definition of an accountable care organization. One that accounts for the care of all 14 million of its patients, even between the times we see them, between encounters. Now, I know this is a hard problem. I'm not naive here. This is a California-sized problem that needs California-sized solutions. And lucky for me, I'm at the University of California to solve this. So I have to thank a lot of people here in helping me create these videos and all this work. We have 40 people on the clinical data warehouse team scattered across the University of California system. I have to thank all of them for making this happen. This is less than a year in now, and we've got this database built. I always have to thank all my funding agencies and my support team, my collaborators here. We can go to the next slide here. Go to the next slide, yeah. NIH, of course, for support, March of Dimes, JDRF, and HP. I always thank my admin and tech staff. I never get anything out the door without them. I always thank my mentors, Zach Kahani, Keith and Sam, for recruiting me to UCSF. I always thank my wife, Doreen Deshmane. I always thank my wife. She reads every major paper grant that comes out of my lab, starts companies with me now, and lets me go all over the place to give talks like this. Thank you very much.